Welcome, everybody. Thrombosis Canada welcomes you to today's conference, and today's focus is thrombosis in primary care. I'm Jeff Habert. I'm a family physician in North Toronto. I wear many hats, but I'm very involved with education. A lot of guidelines. I've sat on the Canadian Stroke Guidelines, the recently published ASA and Primary Prevention Guidelines, and I am the co-chair of Thrombosis Canada Clinical Guides. So I'm your first speaker. We're going to talk about VTE in primary care. What do we need to know? These are my disclosures. As mentioned, I do a lot of speaking and education in the world of thrombosis, mental health, and diabetes. So about this talk, we want to talk about how do we, in our offices, evaluate patients with suspected DVT to help determine whether they actually have a DVT using history and physical exam and the Wells score. And we're going to talk about that. We're going to talk about what diagnostic investigations do we order in our office to help us establish a pretest probability. We're going to talk about initiating appropriate DVT therapy, and most importantly, when do you initiate DVT therapy? And the answer is immediately. So I've given that away. And I think most importantly for us in primary care is to determine how long do we anticoagulate our patients for. So first, a push for Thrombosis Canada, the app. It's a great app, if I don't say so myself. We have currently 58 to 59 guides, but it's not only about guides. There's a lot of interesting stuff on the app. It's extremely useful at point of care. I use it very often. The perioperative guide is very, very useful for our patients. If you use it on the web, you could print it out for the patients. So I'd really encourage you all to download our app. This is what it looks like. This is another view. This is less references for VTE, let's say. Okay, so let's talk about VTE. 45,000 Canadians every year are affected by DVT. That's 1 to 2 per thousand annually. And let's put it in perspective of a typical family practice. A typical family doctor will see 2 to 4 yearly. So the problem is this: 50% will develop PE if they're not treated. If they're not treated, the mortality rate for a PE is 30%. Even with treatment, it's 1 to 8%, but significantly reduced. And obviously, that's the goal, is to treat and to prevent mortality. Let's talk about our case. Jackie, she's a 39-year-old homemaker. Of course, she's coming to see you as one of the last patients of the day. It's 5:30 p.m. She's complaining of lower leg pain for the last 2 days and complains of some leg swelling, which is unlike anything she's ever had before. She's recently returned from a holiday, which included a 10-hour flight, and I'll point you to the 10 hours because it is significant. She doesn't have a cough. She's not short of breath. She's got no chest or back pain. She's a non-smoker. She's got no medical issues. She is on the birth control pill. And when you examine her, the only thing really to find is that her left calf is tender and it's swollen. It's actually 3.5 centimeters more swollen than the right leg when you measure circumferentially. There's no pitting edema, no redness, no varicosities, and her pulses are normal. So what is her pretest probability using the 2-level Wells score? What do you think her probability of DVT is? Likely or unlikely? It's pretty easy. This is a DVT talk. Okay, brilliant. Yes, likely, because we're talking about VTE. Okay, so let's talk about the Wells score. I really have to give kudos to Dr. Wells. This is a Canadian, so important, so impressive. He's still around, still in practice, so really, really impressive. But her Wells score, Jackie's Wells score, is 2. She has tenderness of the deep veins of the calf, and she has swelling, as I mentioned, of 3.5 centimeters. So greater than 3 gives you a point. What the Wells score says that if your score is 2 or higher, your probability of DVT is 28%, and that's considered to be likely. So she's got a likely Wells score. So it's now 5:45. She's the last patient in your office. Her husband's getting impatient. What diagnostic test would you order? Would you order a D-dimer, an ultrasound, both of them, or nothing? It's 5:45. You know, actually, you're all actually right. We're still answering, and I'm going to show you why as we go along, but you're all right. But keep in mind, this is 5:45. She's the last patient of the day. If you're in a primary care private office setting, it's hard to get a D-dimer, but let's go forward. Now, what would you do? So you've decided you're going to order whatever test you're going to order, and we'll go through that. So whether you're going to order a D-dimer, an ultrasound, or both, what are you doing now? Are you sending her to emerge? Are you sending her home without any treatment, bringing her back tomorrow to review the ultrasound that you may have ordered? Start her on apixaban, start her on rivaroxaban, start her on warfarin, or start her on low molecular weight heparin. You know, these are great answers. So B, C, and D are absolutely correct. 7's not wrong, but that's the whole point of this talk. We don't want you to send her to emerge. And the emerge guys are asking that you don't send her to emerge because this is something you can simply treat. So the correct answers in this environment today would be C or D. And let's go through the algorithm. So this comes from CHEST, from the CHEST guidelines. And what the CHEST guidelines say that in your office, if her well score is 2 or greater, she has a likely probability of a DVT. You should start her on anticoagulation immediately, right there and then, and order an ultrasound. We fully understand that you're not going to get the ultrasound tonight. You may not even get it tomorrow. It may be 2 days. Start her on anticoagulation in her office. You also need to know, and I'm going to show you why, you need to understand what kind of ultrasound's being ordered. Are they doing a proximal ultrasound, or is your center doing a full leg ultrasound? In my area, the vascular centers all do a full leg ultrasound. It makes it a little bit easier, but the guidelines actually suggest that it should at least be a proximal ultrasound. And we're going to talk briefly about why that is preferred at this point. I like full leg ultrasound, and you'll see why, because as a family doctor, it makes things a lot easier for us. So what the guidelines actually said in 2016, if you have a high clinical suspicion of VTE, you start anticoagulants while waiting for the results of tests. If you have an intermediate suspicion of VTE, you start anticoagulants. If you have low clinical suspicion, you do not start, but you may or may not do the test depending on where you are. And what they've also said is if you're going to start anticoagulation, it should be one of the new DOACS over a vitamin K agonist and low molecular weight heparin. In this presentation, I'm going to focus mainly on apixaban and rivaroxaban because if you're going to use dabigatran and edoxaban, you need initially to use low molecular weight heparin. Okay, so she comes to your office the next day. You started her on apixaban last night, and her proximal ultrasound is found to be negative. So what are you going to do now? You're going to stop the apixaban, order a D-dimer. You're going to stop the apixaban and order a full leg ultrasound, or you're going to continue the apixaban and order a full leg ultrasound. You know, so in this case, the right answers actually would have been A or B. Because she's been found to have a negative proximal ultrasound, you should stop the anticoagulation, but you don't just stop. So you can either order a D-dimer or order a full leg ultrasound. The third option is actually you can order a D-dimer and then order another proximal ultrasound next week, but let me show you the algorithm. So what the algorithm now says, if the proximal ultrasound is negative, stop anticoagulation and do a D-dimer. But if you can get a full leg ultrasound, you don't need to do a D-dimer because the full leg ultrasound will rule it out for you. And I'm going to show you the full leg ultrasound algorithm in a second, but if you have one originally, it does make life easier. That's why it's very important to know what kind of ultrasound you're ordering. So this is the proximal ultrasound algorithm, and look on the right. So you initiate treatment because she had a likely well score. If the DVT, the proximal ultrasound is negative, you do a D-dimer. If the D-dimer is negative, you now do not have a DVT. But if the D-dimer is positive, it doesn't mean she has a DVT, but it means you either need to do a full leg ultrasound or serial ultrasounds. Serial ultrasounds mean you repeat it in 7 to 10 days. But note what I said before, if you can switch to a full leg ultrasound, you don't need to do a D-dimer. So D-dimer is really interesting because it's not a very specific test, but a negative D-dimer is of great value. A positive one doesn't tell you a ton because there are a lot of things that can elevate it, but a negative one really helps you rule out DVT. So look how much easier the algorithm is with a full leg ultrasound. So full leg ultrasound, if it's negative, you do not have a DVT. If it's positive, you do have a DVT and you continue anticoagulation. The problem with a full leg ultrasound is you can see distal DVTs, which are not all significant, and the incidence of false positives in the distal leg is a little bit higher than we'd like. That's why the guidelines really suggest that we should be doing proximals. But in primary care, it's so much easier if you can get a full leg. Okay, what if the original proximal ultrasound was positive? How would you proceed? Would you continue her apixaban or rivaroxaban? Would you now start her on low molecular weight heparin, or would you start her on warfarin? You're both right. It depends on what you started her on. So I agree with you. If you started her on apixaban, she's positive, you continue apixaban. If you started rivaroxaban, you continue rivaroxaban. I think the teaching point is you don't use warfarin, and current guidelines suggest that you should be using a DOACS favor to low molecular weight heparin and warfarin. And you could use low molecular weight heparin and dabigatran or edoxaban, but why would you when you have two oral options at this point? So here's the proximal ultrasound algorithm. Proximal ultrasound was positive. We continue out anticoagulation. And this is once again the chest algorithm. Why do we do proximal versus full leg? I mean, the biggest reason is that false positive findings for DVT occur more often with ultrasound examinations of the distal veins. Also, only 15% of distal DVT will be complicated by a proximal extension. And if you're doing serial ultrasounds or if you're using a D-dimer by the algorithm, the argument would be you don't necessarily need a full leg ultrasound. My argument is it's difficult to get a D-dimer in our office because the specimen has to be frozen. So yes, we can send them to a lab. They then have to go to a lab. We have to wait a day or two for the results. It's not like Emerge where you can get the results immediately. So that's the issue. In 2020, we talked about this. I won't go through it again, but we do have data. And the recommendation is that we start a NOAC. The easiest NOACs to start would be apixaban or rivaroxaban. You do have an option of using Dabi or edoxaban, but you have to lead that in with low molecular weight heparin. This is the dosing, as you guys have seen before. Apixaban, 10 milligrams BID for 7 days, followed by 5 BID. Extended treatment can go down to 2.5 due to Amplify Extend. With rivaroxaban, it should be 15 milligrams BID for 21 days, and then you go to 20 milligrams daily. And long-term, you either use 20 milligrams, but you can consider 10 milligrams due to Einstein choice. Now remember, thank you, Dr. Bell, actually. Remember, if you're going to do a proximal ultrasound, you need to repeat it if you haven't done a D-dimer and you don't have access to a full leg ultrasound. Okay, so what does CHEST recommend on the duration of anticoagulation? Everyone gets 3 months. So if you have a provoked DVT or unprovoked distal DVT, it should be 3 months distal. If you have one or more unprovoked proximal DVTs, then treatment should be extended, and we'll talk about what that means. So if you look at this chart says isolated distal DVT 3 months, proximal DVT 3 months, first unprovoked extended therapy with review, second unprovoked extended therapy review, cancer-associated DVT should be extended therapy with review. Review means you need to look at the patient's bleeding risk. And generally, you always need to consider bleeding risk. The minimum is 3 months, but if you have an unprovoked DVT, in most cases, you should be looking at extended treatment or ongoing treatment. But there is a proviso, and we're going to talk about that. In terms of risk of recurrence, this is a really cool chart that Kieran actually adapted a little bit in 2016, because what he said is on the left are the clearly provoked VTEs, on the right are the clearly unprovoked VTEs. But interestingly, in the middle are the ones that are minor but important risk factors, such as air travel for great hours or the birth control pill or estrogen therapy. And the reason that some of these were changed to the middle is it shouldn't give you comfort that the patient had a VTE while having a long airplane trip or on the birth control pill, because that's not clearly provoked. It's a minor yet important transient risk factor, and their annual recurrence risk is about 5%. So that had changed because the birth control pill had been on the left, and the thinking was, oh, you had a VTE on a birth control pill, stop the pill, don't worry about it, 3 months. That's not actually felt to be the situation. And now you probably have to have a discussion with your patient, say, yes, you had a provoking risk factor, but your annual recurrence rate is still about 5%. This is a general synopsis of recurrence risks. Unprovoked VTE, that's why we treat long-term. Provoked VTE, the recurrence risk is very low. And the minor ones, the one I just talked about before, 5% at 1 year, 15% at year 5, 4% for an estrogen-containing birth control pill. So in Jackie's case, I mean, just to make it quick, remember, Jackie was on a long flight. She's on the birth control pill. How long would you treat her? And there's a couple of answers here. Would you do 3, 6, 9, 12, or forever? Okay, so 3 is definitely right. The question with Jackie is, would you go forever? So if I wasn't sure what to do with Jackie, I would go to 6 and then I would decide. But the answer would either really be 3 or indefinitely. 6 is fair though, because 6 would be where you'd be at a clinical equipoise and you can make a decision. But yeah, 3 or indefinitely would be your options here for Jackie. But it's interesting actually, because we now have a great tool that we can use with an unprovoked DVT. Men are off the table. Men with unprovoked DVTs are high risk and they need to be treated forever. But now we have a validated tool called the HER-Do2 tool, and I'm going to show it to you. And if you're a woman that scores low risk with this tool, which means a score of 0 to 1, you can actually stop anticoagulation after 3 months. If you're a high-risk woman with a score of 2 or higher, it justifies long-term anticoagulation. Also keep in mind, if you're high bleeding risk, then you need to consider those risks, and 3 months of anticoagulation may be where you're going in any case. But we need to discuss this with our patients. So this is the HER-Do2 score. You get 1 point for each of those. Notice the D-dimer that you have to order. It was validated with a Vitus D-dimer. You can get one of those. You just have to specifically request it. But I also want you to note, if your patient is obese and over the age of 65, they automatically have 2 points. You don't have to do a D-dimer because they will be treatment indefinitely. So that's a big pearl. If you have a female that's 65 or older and she's obese, she needs to be treated ongoing, and she should not be stopping therapy. And this is where the validation came from. As you see with males, it doesn't make a difference. They're quite high risk, whereas females with a score of 1 or less have a very low risk of 3. You see with females that have a score of 2 or higher, the risk is high, similar to the male risk of 7%. All right, we're almost done. What if Jackie was found to have an isolated distal DVT? You saw it on full leg ultrasound. What would you do? Tell her she's okay and she can go on her trip. Definitely start her on anticoagulation. Repeat the ultrasound in 5 to 7 days, the proximal ultrasound, or anticoagulate her if she has high risk criteria. And E is C and D. That's a giveaway. You guys are good at multiple choice exams. Whenever you have a C and D, that's always the right answer. So yes, the right answer here would be C and D. You don't definitely need to anticoagulate distal DVTs, and that's part of the problem with full leg ultrasound. So the answer would be here, repeat the proximal ultrasound in 5 to 7 days to make sure she isn't migrating proximally, and or anticoagulate her if she has high risk criteria. And I'll show you what those are in a second. So we know that 15% of these will travel proximally. I think that's a pretty big number. You have 2 choices: treat her with anticoagulation therapy or do a serial ultrasound after 1 to 2 weeks and see if there's extension. But CHEST and Thrombosis Canada both suggest serial imaging is enough if they don't have any severe symptoms or risk factors. But if they have severe symptoms or risk factors for extension, they should be treated. Here are the risk factors. So D-dimer is positive. The thrombosis is extensive, greater than 5 centimeters. It's close to the proximal veins, and we generally stay within 3 centimeters. She is totally unprovoked. They've got active cancer. They have a history of a VTE, or they're an inpatient in hospital. Those would all be high risk factors for which we would treat the distal DVT. So in conclusion, VT is common. It can have serious consequences. I showed you before, 30 to 35% rate of pulmonary embolus. 50% rate of pulmonary embolus, of which 30% can die. A negative proximal ultrasound does not rule out DVT, so you either need to do a full leg or repeat it. Anticoagulation should be started immediately in your office, pending the result of the ultrasound. NOACs are as effective and safer than low molecular weight heparin bridged to warfarin, so that's now the standard of care. Unprovoked DVT generally requires indefinite treatment unless they have high bleeding risk or they qualify for a negative HER2. And most isolated DVT, in fact, does not require immediate treatment. So thank you, and let's look and see there's some questions. So that's great. So we have a question, serial ultrasound. So I would definitely repeat it once. The question is also, because I now have 7 to 10 days, I would probably also do a D-dimer. I would send them to an outside lab. I get my D-dimer done, and I would do the serial ultrasound. The important thing is not to forget, and I would repeat the serial ultrasound at least once in 7 to 10 days. If I was concerned, I may repeat it twice, but it would also be monitored. It would also be altered a little bit on the D-dimer result. That's a great question. Remember, D-dimer is not something I can rely on in my office like the Emerge guy can, but we certainly now have time with the first ultrasound being negative. I can send them tomorrow for a D-dimer, and I can do the serial ultrasound 7 to 10 days from now. Thanks for that question.